Started right now. If you have any questions, please do not hesitate to ask. And without further ado, I will hand it over to Emma. Thank you.
Hello, my name is Emma Torncello, and I am a psychiatry resident at the University of New Mexico. Today, I wanted to present about telehealth and specifically about expanding access to mental health care through telehealth, specifically to rural areas, as it's particularly relevant in New Mexico, but also throughout the US. This is a brief bio. How to receive continuing education. I don't have anything to disclose. Disclaimer. All right, so today my objectives for learning are first to describe various approaches to implementing telemedicine technologies in order to increase access to mental health care in rural communities and to compare their effectiveness to the traditional in-person care model. The next objective is to highlight key ethical considerations in using telemedicine to enhance mental health care in rural communities. And then finally, I'd like to discuss patient barriers to the use of telemedicine and to explore solutions to address these barriers. So some cultural considerations before I start the presentation. Rural communities are non-homogeneous across the US. Different communities require different approaches to increasing access to care. And also the needs of an individual within a community may differ from the needs of a community as a whole. So, take care to address individual clinical needs while also assessing population level factors impacting healthcare access and utilization. So there's kind of like two things to consider here. One is the population level, and then one is the individual level. Rural communities have decreased access to mental health care. So an estimated 14 to 19% of the US population lives in rural areas. This is nearly 60 million people, roughly. And only 1.6% of psychiatrists in the US practice in rural areas. And this is roughly equal to 47,000 residents per each rural psychiatrist. And as of September 2018, the HRSA designated 2,672 mental health professional shortage areas in rural areas. Almost 60% of all US counties do not have a single psychiatrist. And furthermore, many of these counties are actually clustered together. So it makes it even more difficult for individuals within these counties to access psychiatric care, especially in an emergency, because of the way that things are clustered. One additional thing to add too is that more so in rural areas than urban areas, patients tend to rely on Medicare, Medicaid, and many psychiatrists in rural areas, if they are available, might not accept this means of healthcare payment. So that's another thing to consider as well. Rural communities do have a greater difficulty accessing mental health care. For example, services might not just be available in their area. There can be long wait lists if there are services available. There's increased distances to travel for care. And, with the increased distance comes kind of like taking time off of work, childcare considerations, transportation considerations, things like that in order to actually get to that care. There's limited available public transportation in rural areas compared to urban areas. And there can also be geographic barriers, and this can include geographic features, but also might include climate features as well. And then something to note here regarding lack of access to care. There's a study that showed that although there were similar rates of autism reported in urban and rural areas, rural families reported greater difficulty in accessing resources that were available. And part of these difficulties included long wait lists, problems with transportation, and difficulty actually getting to the care. And so problems with caregivers caring for people with autism were exacerbated in rural areas. And mental health outcomes in rural communities are also different because of the lack of access of care. So suicide rates among rural youth are nearly double the urban rate for both males and females. Additionally, suicide rates in rural communities increased 6.1 times faster than rates in urban communities between 2007 and 2015, according to the CDC. But telehealth increases access to care for rural communities. In general, patients in rural areas typically only have access to behavioral health care through their primary care offices. And those with limited access to behavioral health specialty care due to their location could benefit from the utilization of telemedicine services to improve their access. Some examples of telemedicine that might be utilized to increase access include direct telehealth visits, asynchronous telepsychiatry, e-consults or consults of care maintained and delivered by the primary care, the collaborative care model, and emergency room telepsychiatry. So I'm going to expand on a couple of these, but worth mentioning, direct telehealth visits is kind of what we think of when we think of, your standard telehealth visit, where it's essentially a typical office visit, but it's done via telehealth technology, whether it's video conferencing or over a phone interview. So that's kind of the standard. And then another one worth mentioning too is emergency room telepsychiatry. I don't expand much on this, but essentially what it is it's delivering psychiatric services to the emergency room setting using telehealth in order to meet the need of patients there. So the first one I'm going to talk about is actually asynchronous telepsychiatry. And what this is it consists of typically a video recorded interview of a patient that is delivered to the mental health professional providing evaluation and or recommendations. And this is done not in real time. So the video will be uploaded, and then at some later time, the mental health provider will perform the evaluation and then provide recommendations and somehow relay them back to the patient. So the keyword is that it's asynchronous. The use of asynchronous telehealth technology has been previously established in other fields in medicine like pathology, cardiology, radiology, and dermatology. So here's a study that was actually done in order to evaluate whether asynchronous telepsychiatry was feasible in providing care that's culturally relevant and appropriate for individuals with limited English proficiency. This study looked at specifically a population that primarily spoke Spanish. And essentially what they did is they recorded interviews with a Spanish-speaking mental health professional with a patient, uploaded that, utilized technology or interpreter services in order to interpret the interviews into English, where an English-speaking psychiatrist was able to view the interview and the transcription and provide recommendations and evaluate the patient. And this study actually showed that it is quite feasible to do this, and the evaluations were accurate, and it did, show promise in increasing access to people who otherwise might not have access to services in their preferred language. So this research supported asynchronous telepsychiatry as a means of overcoming the need for real-time interpreters to deliver effective mental health care, which can be a major barrier for people living remotely. We think of the lack of mental health providers in rural areas, but also the lack of interpreters, translating services, things like that could also affect access to care as well. And the article also says that other potential uses of asynchronous telepsychiatry could include people within the prison system, people in military service, or other difficult to access groups who otherwise might not have access to psychiatric services. Another means of utilizing telehealth is consults through primary care. So the traditional consult model is patients seen by their PCP. PCP identifies a need for behavioral health specialty care and refers to that specialty care. And then the patient would go to that other provider's office and receive the care. But this can also be done through e-consults, especially where mental health care is not available geographically. So a primary care provider might be able to reach out to a psychiatrist via an e-consult and request chart review or recommendations, and then the psychiatrist can provide recommendations in that manner. There's also integrated care strategies. So this can also look like a psychiatrist co-locating within a primary care setting. Although again, this does require a psychiatrist being physically present at the location of the service. And then finally, I wanted to talk about the collaborative care model. So this is a model that was recently developed, and there's a lot of excellent research that supports its feasibility and efficacy. So essentially what this model looks like is, I have a diagram right here that sort of explains a system, but basically it's a very integrated system where patients are primarily interacting and interfacing with their PCP. And there is quite limited direct contact between the patient and the psychiatric consultant, but the patient is frequently interacting with their PCP and with a role called a behavioral health care manager, who has gone through certain training, has certain qualifications, might be a case manager or a psychiatric NP, someone who's familiar with patient care. And essentially what happens is the patient primarily gets their care from the primary care doctor. But this is also, their mental health care is coordinated through a care manager. The care manager is responsible for seeing multiple patients who might be patients of this primary care provider. And the care manager manages a registry of the patients, which gathers data about the patients and certain psychiatric screening methods. So for example, part of the registry might be the patient's name, age, diagnoses, and it might keep track of sequential PHQ-9 scores, for example. And then every so often at regular intervals, the psychiatric consultant will meet with the care manager to go over the registry of patients and to evaluate the registry and provide recommendations. And then the care manager can sort of talk more with the psychiatric consultant, clarify any questions that there are, and essentially kind of relay recommendations by the psychiatric consultant that would be carried out through the patient's primary care office. So in essence, it's kind of complicated, but in essence, it's behavioral health care that is provided through the primary care office, but guided by a psychiatric consultant. And so in essence, the collaborative care model does apply concepts of population-based care to implement, psychiatry care at the population level. There's a substantial body of evidence supporting its effectiveness. And one pretty significant barrier for implementation of the collaborative care model is payment strategies, because the way that our current payment structures work and the way that current infrastructure is, it can be difficult to initially implement this in a way that's feasible and that works for the providers involved. So here's some other sort of, miscellaneous examples of telemedicine. One thing that I wanted to talk about is Grand Lake Mental Health Center, which had a program that began distributing internet-connected tablets at the time of discharge to any recipients of crisis services at their facilities. And these tablets were set up to allow these patients 24/7 access to staff. Psychiatric staff at this facility. And additionally, in providing tablets to these patients, this service also provided tablets to local law enforcement to expand and involve them in the process as well. And so essentially in 2015, prior to the launch of this program, more than 1,100 individuals were admitted to inpatient beds in the region, and almost all of them were brought in by police or law enforcement. So after this program opened up and started distributing tablets, the number plummeted from 1,100 individuals admitted to inpatient beds to just one person in 2020. So it seems like this was a very effective way to deliver telehealth that prevented admission to crisis services. And then UNM's Project Echo is also an example of telemedicine as well, by means of just sort of educating people within the community, outreach, sort of having a panel of people that can educate based on patient care and provide guidelines as well. So that's another way to utilize telemedicine. Some ethical considerations for telemedicine include security and privacy. So privacy and confidentiality may be a barrier when delivering telehealth services. Some patients might want total anonymity for personal reasons. And then public Wi-Fi or internet in public areas might be some people's only means of utilizing online telehealth services. So, for example, if a patient's only means of connecting to the internet is using a public library, that might pose some barriers in providing mental health care that is safe and confidential and makes the patient feel secure. This may include unhoused individuals or individuals living very remotely that might not have a strong internet connection. Additionally, other things to consider is the safety of the patient's broadcast site, whether they are attending their visits from home where there might be domestic violence involved, or concerns for their privacy. And so another thing to consider too is, allowing for informed consent with your patients, saying that you can terminate the call at any time, allowing them to switch from a video call to a phone call at any time, and just really, working with the patient to ensure their safety. It's important to always use a secure and trusted platform for video, and then ensure your device uses security features such as passwords and two-factor authentication, and ideally try to avoid storing patient data locally on your device. And if it's unavoidable, the information should be encrypted. These recommendations come from the APA's Telehealth Toolkit, which is a great resource. It's available on the APA website, and it goes through a lot of the logistics of telehealth as well. So for patient-related barriers, consider alternate means of delivering remote care. So for example, if a patient doesn't have a video conferencing capability available, you can use landlines, asynchronous care. You can utilize e-consults through the patient's PCP like we discussed before. And you can also offer telemedicine appointments within a local medical office setting if that's something that's available to them, where a patient might present to a PCP appointment for a nurse visit or even for their regular primary care visit. And then be subsequently set up with a telemedicine capable technology within the office setting where they can connect to a mental health professional. Some barriers to care, including legal and financial considerations. So something to consider is licensing requirements. In general, physicians must be licensed in the state in which the patient is receiving care, regardless of where the physician is. This is overall the general rule. There are some very few exceptions, but this is overwhelmingly the case. And insurance and payment considerations also come into play. Current healthcare payment structures may not yet support new or emerging systems for delivering care remotely. And as we discussed before, this would include the collaborative care model. And so kind of navigating that system might be a little bit difficult for providers in initially implementing these various forms of telehealth care. Patient access is also a barrier to care. So something worth considering is the digital divide. And this refers mainly to discrepancies in access to technology or internet services for any variety of reasons. So it can include, perhaps access to care or to resources, but maybe like only lower quality resources, such as lower quality Wi-Fi, or lack of available internet access altogether. It can also include lack of comfort with technology use, which might include older adults and elderly patients. And then it would also encompass diagnostic considerations as well. So for example, if you had a patient with conditions that affected their cognitive functioning, their ability to learn to use these resources, or in some way affecting their ability to utilize technology in a way that enables them to obtain necessary care. So for example, if a patient had dementia, it might impact their ability to learn to use telehealth technology services, and that's a consideration. And here's some data that I found about broadband access for people in rural versus urban areas. And as you can see, a significantly lower proportion of people had high-speed broadband access in rural areas compared to urban areas. Another barrier to care includes language and cultural considerations. So it's really important to educate yourself about the cultures and the environment in which you're providing care. Because telehealth allows us to deliver care remotely, it does, represent a barrier between provider and patient and the location that they're receiving services. So it can introduce a situation where you're unfamiliar with the area and the culture that you are treating. And so it's really important to stay up to date on news and events impacting these communities, to educate yourself on the culture in which, your patient is a member of. And the APA Telehealth Toolkit recommends considering periodic site visits to the communities where your patients reside, in order to better facilitate an understanding of the environment where your patient is, because you might not be able to experience it otherwise if you're only providing remote care. And then other things, as we talked about before, with language barriers, it's really important to utilize professional interpreter services, and if at all possible, avoid relying on family members or companion interpreters for the patients, because this just introduces a whole element of, potential bias or risk to the patient, or a burden on their family members or on the patient too. And this is important in all medical specialties, but especially so in mental health care, where the interpreted information might be quite sensitive. And so if at all possible, utilize professional interpreter services. So ways to improve accessibility to telehealth. Prior to an encounter with a patient, it's important to assess for the patient's accessibility and technology needs. And you can assess for the need for communication aids, assess for the need for interpreter services. One way to do this is to call patients ahead of their appointment to confirm that they have the necessary technology available for use, and also to confirm that they know how to use it as well. And then you can also offer alternate means of delivering care, such as phone call appointments, or completely alternate means of delivering care. There's some accessibility features that certain platforms offer. One of these is communication access real-time translation captioning, live captions, automatic transcriptions. These can be really, really useful for patients that are hearing impaired or hard of hearing. Chat and text features are also useful in these scenarios, and also high contrast display for people that might have visual impairments as well. And so overall, the effectiveness of mental health interventions via telehealth compared to the traditional model, which is one of the goals that we wanted to examine today. So there are many, many studies that support that telehealth is very effective at delivering care. This study found that video conferencing appears to be as effective as in-person care for most parameters, such as feasibility, outcomes, age, and satisfaction with a single assessment in consultation or follow-up use. Another study said that patients who had a hybrid care had improved timelines or timeliness of care and an increased number of total outpatient encounters compared with patients who had only in-person outpatient visits. These findings indicate that hybrid care may be more effective than in-person visits alone, and suggest integrating telepsychiatry consults into traditional in-person care systems. And a caveat to note, in this study, an increased number of encounters was seen as beneficial because these were patients that required significant close follow-up as well. So this was seen as an overall successful implementation. So in conclusion, overall, data supports non-inferiority and in some cases improved efficacy when compared to traditional models of care. Certain populations, actually particular children and adolescents, may be better served through telepsychiatry. And then I have a study here that states that with children and adolescents, telepsychiatry may be better than in-person services because of the novelty of the interaction, direction of the technology, and the psychological and physical distance, and as well as the authenticity of the family interaction that you gather through telehealth. And overall, telehealth increases access and decreases barriers to care for individuals living in rural and remote regions, and the evidence does support this as well. And here are references, and here's an evaluation link and the QR code for that. If anyone has any questions, I'm happy to answer. All right, no questions. All right, thank you so much.
Thank you so much, Emma. We really appreciate you coming through today and giving this presentation. And hopefully this will be up on the YouTube account in about a month or so. And if you have any questions about the CE information, feel free to reach out to me directly. I'll also share it in the chat right now. But yeah, thanks again, Dr. Torncello, and we'll see y'all next time.
All right, thank you.
Thank you.